Good afternoon, everybody. I'll be showing one of the cases which I got stuck. And if you can see, there is a dark black glow. And if you have this dark black glow, then be attentive. You are going to face some problem. So this was a case of organized vitreous hemorrhage. I couldn't see the retina. Ultrasound showed mounts, and I misdiagnosed it as rhegmatogenous retinal detachment. So I went on to clear the vitreous hemorrhage. There was almost a total PVD, and you can see the hemorrhage is pretty thick, and it's coming as N block. And once you see the posterior pole, you can see this mounts almost 360-degree. I have never seen this mounts 360-degree appearing like choroids, but actually these are not choroids. So what I tried putting PFCL so that these mounts tends to settle, but with PFCL there was no alteration in the mounts, and you can see we can visualize the disc with lot of difficulty. You can see dark black areas here of vitreous subretinal heme and clear area, and this is the clear area. So at this stage, I just want to put in question, what is the diagnosis? I think with the August gathering, the diagnosis is clear as PCV. So my first question is, should we leave this or drain it? If drain inside or outside, leave it on gas or oil. So questions are open to the panel.
MPS, sir?
Yeah, this is PHCR and it's subretinal blood. That's what you can see. So draining from inside can be difficult because it can be actually thick, and like the way it is not moving with the PFCL inside, so it may be difficult. So I would usually do external drainage, use a cut down and then drain. And sometimes what I've done is like multiple places I have drained and left them open also. So the blood drains in the postoperative period also. That's what I have done.
Any other comments?
Sir, is there any role of putting subretinal TPA in these patients and then drain externally? Because a lot of times we get these clots getting stuck in the external drainage, choroidal drainage areas.
Yeah, you can, but this one is most likely most of it is liquid, is what I would think, because it's not probably clotted. And so I would think like you can try it, but then like if you have to put TPA, then you don't know, because like this is we are seeing it like what do you call Dr. Avnindra is showing us now, but then like when he went inside, he wouldn't have known that there was some little blood, isn't it?
I'll show what in continuation what I did, sir. And it was a nightmare for me in this patient. So what I did, what Dr. Mahesh told, he tried to drain from outside. So I made a sclerotomy just behind the limbus. You can see some fluid coming out from here, but I went inside and saw there was no change, absolutely no change. Then I have seen one video from Manisha's side where she has drained the choroids. So I thought I should drain from inside, and I made an drainage retinotomy, and you can see a lot of blood coming out, and it keeps on coming out and out, and still there is no change uh, in the structure. Then what I did, I penetrated the choroid, and you can see some blood coming out. But again, I went inside and saw nothing happened, and you can see laser coming nicely, so there is no detachment. But now the patient has full hyphema, and I have drained the hyphema also, but of no success. So uh, extremely difficult cases. What I thought I made a mistake. I don't think so. We should drain from inside, because if you drain from inside, you can land up with the bleeds, what Dr. Mahesh has suggested. The only thing what I should have done is I could have left with alprabacept inside with oil, and don't drain it either from inside and outside. That's what I learned from this case.
So I think that, Avendra, what I had shown the internal drainage was not the suprachoroidal blood.
Yeah.
The second thing is that even one or two cases which I have operated, I don't have as much experience as MPS sir or PB sir, but these cases very often, even after you have operated, there's a lot of clotted blood that you get. And even if you have managed to remove those clots, there's a extensive RP atrophy present. So visually, I don't think that the patients really gain even after you've done the entire clearing up of the blood and all. So I really don't know that if the other eye is good, do we really intervene with a surgical procedure in such eyes? I don't know what is the suggestion of others.
Can I add something? Yeah. Okay. Basically, I think it's there are two things here, whether we are dealing with a subretinal blood or suprachoroidal blood. And PCV generally what we look at it, there's a lot of subretinal blood also, and what Manisha rightly mentioned, and quite sometimes it is clotted. It is stuck to the RP, stuck to the retina as well. And total complete clearance will never ever be possible in these eyes unless you do large retinotomy, maybe 180 degree or more than that, and really scrape out all these things. So that is one thing. But that is more giving you satisfaction, you drain it. But as I said, already a lot of blood and already photoreceptors are damaged because of toxicity. Functional outcome is going to be significantly less. Coming to technical part, as I said, once you make a retinotomy or any opening, and because you cannot drain entire blood, and had that powdery stuff keeps on coming and coming and coming, and what post-operative period you saw hypema, repeatedly hypema, you keep on washing. So best way sometimes just leave it as it is, not to remove, because damage has already been done. Okay. So if there is a limited blood, then probably TPA and all those things you can work around. But if it's such a massive clot all over in a subretinal space, how much TPA? And TPA will act as some limited area. Even if you go in a subretinal TPA, that localized area, it will just liquefy. But what about other clot? So these are difficult cases. A lot of practical issues are there. Suprachoroidal, as you may rightly again mention, unless you cut choroid, I mean, suprachoroidal blood minimal will come out, but subretinal blood to drain through suprachoroidal space, you will have to cut the choroid. And there is always risk of cutting some choroidal vessels and inducing some more bleeding. So we do not know, because cutting choroid will be blindly you will be doing. We do not know what it is. So there is a difference between draining suprachoroidal blood externally and draining subretinal blood externally. Okay. So that we have to keep in mind always. But if you want to go all out, then I would prefer to do large retinotomy, take everything out, then use PFCL to flatten it out. Yes, I mean, anatomically you will achieve success, but don't do half-hearted job. Either do complete or don't do retinotomy at all. Just leave that blood as it is. Eventually it will get absorbed. At least it will not keep on coming in an antechamber, not coming in a vitreous cavity. Again, media will be easy. It will remain because damage has already been done.
So, oil or gas, sir, after the end of the surgery?
Well, if you don't make a retinotomy, if there is no hole, no gas, no oil. But once you have made a retinotomy, obviously you will have to have oil only there, because of a large retinotomy. And the laser, what you got?
This patient?
Yeah, because laser you got because of retina and a blood clot, not retina and RP. So eventually long term it will not hold on, because it is not adhesion between RP and retina. Okay, that also. Counseling is very, very important to diagnose this pre-surgery. Good ultrasonography, good history, and talking to patient that yes, we are trying to clear media. It may benefit visually, may not benefit visually also. So actually, if there's PVD already there, other eye is good, and you strongly suspect suprachoroidal, see, eventually this vitreous cavity blood is going to clear, whether you surgically remove or allow it to clear over a period of time. Final vision is going to be same. Okay. So, but if you give benefit of doubt, suppose there is a localized area of heme, certain mounts will be there, but there are always few islands where retina is attached. And if that area is functional, definitely vision is going to be better than leaving it like that. So we need to talk to patient, give enough time the patients and attendant to make their decision before going in. We have to make this very clear.
We need to actually